Thank you, Sue, for inviting me and for, I think, the very nice introduction of myself. I mean, I didn't understand much because I don't understand Korean, but by looking at the slides, I think, yeah, you kindly introduced me. I will be talking about social inequalities today, and previously I thought about doing a presentation on social inequalities during the COVID-19 pandemic in Germany. But when I started to go through the literature and the studies that are available, I soon realized that there are not enough studies available right now to fill 45 minutes. So I had to take advantage of the colleagues from Europe that already published a lot of studies showing inequalities in COVID-19 from Europe. So we will not be only looking at evidence from Germany, but we will also be looking at evidence from Europe in general. And over 100 years ago, in 1918, the world last experienced a pandemic of the scale of COVID-19. And I'm not sure if you have heard about this pandemic, but if you're in public health, you probably have. This was the so-called Spanish flu. And the Spanish flu pandemic swept across the globe in 3 waves, actually very similar to the COVID-19 pandemic, where a lot of countries and a lot of European countries are experiencing 3 pandemic waves, and we are now waiting for the 4th wave, probably starting in fall. The Spanish flu infected around 500 million people, which was 1/3 of the world's population back then, and it led to an estimated 50 to 100 million deaths. And the death rates were particularly high in Europe, which has been affected by war, and among those aged 20 to 40 and older people. And already in 1931, a little bit more than 100 years later, Edgar Seidensticker put forward that there were significant inequalities in the Spanish flu. And it was not only inequalities by age, but there's historical research now demonstrating that there was a clear social gradient. As such, the infection rate and mortality rates were higher in less affluent neighborhoods, among the working population, and in urban areas. And when we look at this figure, for example, which shows that greater mortality of the Spanish flu was observed in census tracts with higher illiteracy rates. That means the death rates were higher in areas, and this is from the United States, where people were unable to write and read. And this is represented by the yellow squares. So the yellow squares and the red squares show that the illiteracy rate and the death rates and death rates. And as the pandemic progressed, the disease spread to the neighboring tracts, but remained pretty concentrated in the high illiteracy rates or areas. And another fairly recent pandemic that is also providing evidence for existing inequalities in infection, disease course, and mortality was the rather recent pandemic of 2009. In Europe, we often refer to it as the swine flu, but in many other countries, it was also called the H1N1 influenza. And here evidence, for example, shows that the exposure risk was associated with race and ethnicity, that hospitalization was associated with lower educational attainment, and that mortality was associated with neighborhood deprivation or deprivation in general. And when we look at the table to the right hand, we can see that mortality, the mortality rate was actually most deprived in areas and was higher in the most deprived, actually 3 times higher in the most deprived areas in England. So when you look at the most deprived areas, you can see that the deaths here was 118, whereas the least deprived areas, it was only 42. So in death rate per 1 million, it is around 12, and here it is about 3.9. So about 3 times higher in the most deprived, so people with low income, low education, poor work, employment conditions, etc., were most affected by the swine flu. And It actually, as a social epidemiologist, it came to me as a surprise when claims were suddenly made when the COVID-19 pandemic started that we are all in it together. In Europe, there were news and politicians and the media that put forward that everyone is affected equally by the COVID-19 pandemic and that the COVID-19 virus does not discriminate. But given the inequalities that we experienced already in 1819 and in 2009 with the swine flu, it seemed to me that this is impossible and that the COVID-19 pandemic must discriminate and we are not all in it together. And actually, and very luckily, a lot of researchers from across the globe and social epidemiologists and public health researchers thought the same and were very quick in providing significant evidence that the pandemic does in fact not affect everyone equally. In the UK, for example, COVID-19 death rates are twice as high in the most deprived areas and neighborhoods compared to the most affluent. Infection rates are higher in deprived regions and among people with low incomes and in urban compared to rural areas. So they are higher in more populated cities. Today, I will be talking about the direct effects of the pandemic. And this is the first part of the presentation. I will talk about the inequalities that we are experiencing in COVID-19 in Europe. And as I said, I previously thought about doing this only for Germany, but the literature is so scarce and only slowly emerging, and therefore I'm referring to evidence from Europe in general. I will then also talk about possible mechanisms and pathways leading to the inequalities in COVID-19. And then I will talk about the indirects of the pandemic, and this will be the second part of the presentation. We will talk about health inequalities during COVID-19 and especially mental health. So not only the direct effects of the pandemic, but also the indirect effects, for example, caused by lockdowns. And we will talk about inequalities and psychosocial strain. So in Europe, probably the first evidence that showed inequalities was emerging from Spain. It was a study published by the Catalonian government in April 2020. And the data suggested that the incidence rate of COVID-19 was about 2.5 times greater in the most deprived areas. So areas with less income, less education, and yeah, always compared to the least deprived, so people with more income or areas with more income and higher educational level. And in Barcelona, for example, the districts with the lowest per capita income had the highest incidence of COVID-19 per 10,000 inhabitants, whereas the districts with the highest mean income, so people with the most amount of money, had the lowest income. And this study was published in 2020 and is available to read. I believe it's open access. So we have inequalities in infection risk by income. We also have evidence actually from Germany concerning inequalities in infection risk by income. And similarly, early data analysis from Germany found inequalities in income and incidence rate. However, as you can see in the slide or in the figure, the association or the trend was a little bit reversed. Down here we see red means low income groups, blue signifies middle income groups, and green is high income groups. And we can see that especially at the onset of the pandemic, so in March and April 2020, in Germany, it was actually people with higher incomes that were more affected by COVID-19. And this trend kind of progressed until about October, November. This was the second pandemic wave in Germany. And then suddenly in December and January and February, the trend changed and low and middle income people suddenly experienced an increase And the trend continues, especially for low-income people, to be higher. So incidence rates are now higher among low-income people. And it's important to say that in December or November, after the second pandemic wave, Germany introduced a nationwide tightening of the infection control measures. We call this the lockdown light, because it is a lockdown light compared to Italy and France, where people were not allowed to leave the house at all. In Germany, we were still able to go outside. So we were still able to do our regular groceries and also to meet people. At the beginning, it was a group of 10 people that we were restricted to meet, and then later only 5. But we never went under severe lockdowns such as Italy, Spain and France, where we were only able to go outside for the essentials. But we were still pretty much able to continue our normal life, just with a restriction of meeting people. And it is interesting that especially then when we had this contact restriction, lower income people were more severely affected or had higher incidence rates of COVID-19. We also see that there are inequalities in infection and hospitalization, and we see this especially for employment. Evidence from the UK, for example, shows that individuals with the lowest level of education are more likely to be hospitalized compared to people with higher levels of education. And we can see when you look at the figure here that the relative risk, for example, or the risk ratio is about 2 for people with no education. So this is low education and no education compared to people with higher education, as you can see in the middle. And these are 3 different models that were adjusted for several covariates. But we can see that the risk ratio is much higher for those who have a lower level or no education at all compared to those with a medium level of education, or even those with a high level of education that allows them, for example, to enter university. We also see that there are inequalities in hospitalization and in employment. And this is data from one of my colleagues here at the Institute of Medical Sociology, and he looked at differences in hospitalization by employment. So he looked at people who are regularly employed with a full-term or part-time contract, those with a low-wage job with social benefits, those with short-term unemployment. Those are usually people that have just become unemployed and have get a payment from the German government for about 6 months, and that helps them to reintegrate into the labor market, and those with long-term unemployment. And we can see again that those with long-term unemployment, those are people who have been out of the workforce for longer than 6 months, have an odds ratio of almost 2, so 2 times higher odds of being hospitalized compared to those who are regularly working. And we will talk about the pathways and mechanisms why this might be so, that especially long-term unemployment individuals are more affected later in the presentation. Then again, we have inequalities in hospitalization also by income. And the finding that I've just shown from Germany was actually supported by findings from Paris. However, the study found that the factor most strongly associated with hospitalization was actually income. So unemployment was associated with it, but income seemed to be even more associated with hospitalization, which I think is not very surprising, because usually people in unemployment also in France have very little income to support their daily lives. And unemployment and income are strongly correlated. And other indicators that were associated with COVID-19 hospitalization were, for example, the occupational status, so what the people did for work, were they working from home, were they working with people in the healthcare sector, etc. people living in public low rent housing, so people or housing that was subsidized by the government. Those are usually characterized by overcrowding and really poor or precarious housing conditions. And another factor that was associated with hospitalization was the immigration status or the migration background. And there's actually striking evidence from the United States that there's a strong gradient for hospitalization for COVID-19 by race and ethnicity. And the COVID-19 inequalities by ethnicity are particularly present in the United States, especially when compared to Europe. But there's also more and more evidence now for Europe showing that racial and ethnic minority groups are more often hospitalized compared to the non-ethnic racial and minority groups. And this, for example, is a study from England. And when you look at the graphs, you can see that Black and Asian populations have a much higher rate of being hospitalized than the white British population. So when you look at the Greater London area, you can see that here the rate was around 47.1 for Black people, 36 for Asian people, and then only 12% for white people. And this trend can be observed through all the areas in England. So people in Europe with a migration background or race and race and ethnic minorities usually have worse health outcomes than people without a minority background, and especially compared to whites. And I mean, this could be due to poor health literacy, that they don't know where to get access to, that they don't know how to go to the doctor. This is especially the case in Germany, that people are lacking the competence, the health competence to get information, what is included in the insurance. Then we also see strong inequalities in mortality. So we had inequalities in infection rates, we have inequalities in the disease course, and now we have also inequalities in mortality. And this figure, for example, shows the standardized COVID-19 related mortality rates among men and women in areas of socioeconomic deprivation and calendar week in Germany. And the dark blue line, for example, represents the most deprived areas, and the light blue line, the most affluent or least deprived areas. And we can see that starting in calendar week 40, the most deprived areas had higher death rates per 10,000 people compared to the light blue line, the least deprived. And this is observed for both men and women. Men and women again in week 40, and then we have a peak in about week 50, and then we're starting the new year with week 2 and 7, and the rates continue to be much higher for economically deprived areas. Then we also see inequalities in mortality and occupation. So we have this large-scale analysis by the Office of National Statistics from England, and they found that in England and Wales, COVID-19 death rates in the first wave, so March to May 2020, were highest among men employed in elementary occupations. And we can see that here's the elementary occupation for males, and here the death rate was around 39.7 per 100,000 deaths. And these included, for example, men employed in construction or security guards and factory workers and cleaners. So people that have regular contact to people actually, especially factory workers. And then those were followed by occupations in caring, leisure, and other services. So, for example, healthcare professions. And of course, they had a pretty high death rate because they're more likely to be exposed to the COVID-19 or the SARS-CoV-2 virus. And then they're followed by process and plant. And the least death rates occurred in more professional occupations, an associate in professional occupations, or among managers, directors, and senior officials. And while the trend is not so drastic, or the inequalities, occupational inequalities are not as strong for women, we can still see that women working in caring and leisure time, or also in process, plant and machine operatives and elementary occupations, have much higher death rates compared to females working in associate professional technical occupation, or managers and senior officials. And this can mainly be explained by the fact that they have frequent contact to people, and that these occupations in Europe were also considered key occupations. So they had to continue working, and they were unable to go and work from home. Then we also see inequalities in COVID-19 mortality by migration background. And this study, for example, shows the hazard ratios of dying from COVID-19. And it shows that migrants have a higher mortality of COVID-19, especially if they were from lower income countries, as we can see here and here. And those are the COVID-19 deaths represented by the blue squares. And the trend is surprisingly actually reversed for other cause mortality, so other causes of death. So this could be cardiovascular diseases or stroke. And actually here the hazard ratio is below 1, and the risk is less common, or the risk is lower for people with a migration background to die of other causes for diseases, but it is especially high from people with a migration background to die of COVID-19. And when we think about the pandemic and the slides that I have just shown you, the income, education, migration background, those are all considered the social determinants of health. So it appears that the COVID-19 pandemic, or that the inequalities in COVID-19 does not occur by chance, but it's due to a factor or a combination of factors, as we may term it, the interaction with the social determinants of health. So it appears that it's not only COVID-19 that is causing the inequalities, but that it's a combination of the social determinants of health that we are experiencing with COVID-19. And the mortality rates and infection rates are therefore rising, as Claire Bamber would term it, a syndemic pandemic. So we are experiencing a syndemic pandemic. Claire Bamber is a professor, a public health professor from the United Kingdom, and she took up sociological concept of Merrill Singer, of a syndemic, that several factors interact with each other and then enhance the risk, or pose an even bigger and more complicated problem. And as she would put it, we are experiencing how the inequalities that we have experienced in the past and now are building a toxic relationship. So inequalities in the past, given we had inequalities, are we experiencing inequalities in not only COVID-19, but also cardiovascular diseases, respiratory diseases, now combined with inequalities in COVID-19 and inequalities in the social determinants of health, inequalities in education, etc., form a toxic interaction, leading to the even severe inequalities we're experiencing now, and we will be experiencing also after the pandemic is over. And I think there are several pathways that can explain inequalities that we're experiencing, and I would usually refer to a model from the WHO, which is shown here. It's the final concept from the WHO on how social determinants or social factors can lead to inequalities in health. But when I went through the literature, I came across a lot of different models, and I think one was very fitting, especially given the current pandemic situation. So it might be that the model by the WHO is not the most appropriate, but that there is another very appropriate model. And that is a conceptual framework that was developed by Quinn and Kumar. And the model shows the proximal and the distal factors that can lead to inequalities, especially in epidemics. So this is a model that was specifically developed for epidemics and influenza epidemics. And we have the distal factors that are, for example, the population structure, such as crowding, access to clean water, the ability to stay away from home, which plays a significant role during the COVID-19 pandemic. We have the psychological stress, the nutritional status, and so on. And then we also have the proximal factors, which are, for example, hand washing and social distancing behavior, vaccination behavior, which is a ever more present problem in Europe and especially in Germany, that we have a lot of people who are hesitant to get vaccinated. And then we have also the healthcare utilization, so uncontrolled chronic conditions. People in Germany tended not to go to the doctor anymore when they were feeling sick, or they were afraid of going to the doctor because of the fear of infection, that they would get COVID-19 if they get admitted to a hospital. And I think there are two specific pathways. We have the susceptibility and vulnerability to the pathogen and contact and severe disease course. And this is represented by the psychological stress, the nutritional status, and the behavior, etc. And then we have B, exposure, risk, and transmission. And this is, for example, the population structure, the access to clean water, and the ability to stay away from work and to work from home. And for the remaining course of this lecture, I will look at these two specific pathways. There's actually a third pathway, which would be this one, but I will not go into depth given the short amount of time. And yeah, we will start out by looking at susceptibility and vulnerability. Why are people more susceptible and vulnerable to getting COVID-19 or in general a disease? And then we will talk about the exposure risk and the transmission. So why some people are more exposed or more likely to get exposed to the disease. Yeah, so looking at the pathway and susceptibility, we can see that it is not equally distributed, and that some groups, for example, are more likely to be vulnerable to disease outcomes than others. And this is a study from Germany. It's actually already from 2009, but data didn't change much. And this figure, for example, shows that there is enhanced risk for some people, and especially people living in poverty, of experiencing diseases such as heart attack. So there's a markedly higher risk of experiencing a heart attack when you're poor compared to when you're not poor, for women and men, for experiencing stroke, for chronic liver disease, for other cardiovascular diseases and diabetes. And there's also a higher risk for experiencing diseases such as high levels of blood cholesterol, chronic bronchitis and asthma, but also depression and osteoporosis. So people living in poverty usually have a higher risk of experiencing certain diseases compared to people who are above the poverty line and who are more wealthy and more affluent. And these chronic diseases actually make people more vulnerable to COVID-19. We know that when you suffer from asthma, for example, at least in Germany, this has been considered a risk factor for a severe COVID-19 disease course. We also see, for example, that the risk of asthma is increased for people experiencing job insecurity. Although we have a very good social security system in Germany, less affluent people and disadvantaged people more often live under precarious living conditions, such as high density districts next to frequently and used highways and roads, and little access to green space. And people with job insecurity in Germany are usually those people that are working under a short-term contract. So their contract is going to be finished, for example, in a year or sometimes 6 months, and people that have a low income and so on. And these people often have a high risk of being or feeling job insecurity, and therefore are often also less likely to afford good living conditions and a clean and big apartment, because they have an unstable income. And the disadvantages in job also often, as I said, lead to precarious housing, and disadvantaged individuals are often more frequently exposed to high levels of air noise and pollution than advantaged groups, and the exposure to air and noise has been linked to several negative health outcomes, including respiratory diseases, cardiovascular diseases, anxiety and depression, and sleep disturbance. And these poor housing and living conditions increase the vulnerability of people by increasing their susceptibility to disease. So they are more vulnerable to disease because they live under these precarious conditions, and are more likely to get sick and to develop a chronic condition, and are therefore more likely to get infected with COVID-19. Especially because those chronic conditions often weaken the immune system, and the longer they are exposed to precarious housing conditions, the more likely they're to get sick, and the more likely their immune system will suffer and be weakened. Then this actually goes hand in hand with the exposure and transmission risk in living conditions. As I said, inequalities in housing may contribute to inequalities in COVID-19 because these deprived neighborhoods or residential complexes often lack outside space, and they have a higher population density, so more people are living within one building, and they also tend to have a higher transmission rates because they are unable to separate themselves when they actually get infected with COVID-19. So they have less ability to practice physical distancing and to self-isolate. In Germany, a lot of those complexes for low-income people have only a 2 or 3 bedroom apartment, and there are quite a number of people living in those, and you may imagine that once a person gets infected with COVID-19 and there's only 1 bedroom and 1 living room, it becomes difficult to separate, especially if they have children and if they're sharing bedrooms with other people and so on. And when we look at this figure, this is also from Germany. It shows the age distribution of SARS-CoV-2 cases in Germany. We can see that poor housing conditions, such as overcrowding and high density, are associated with the greatest spread of COVID-19. And here, this is a study from Göttingen, which is a town in Germany. The authors or researchers looked at 2 residential complexes and compared them to the general population in the town of Göttingen. And these 2 residential complexes are characterized by overcrowding, so a lot of people living in one space, littering, so a lot of trash, and in general, very precarious housing conditions such as mold. And you can see that throughout the age groups, the incidence rates were much higher among people living in residential complex 1 and 2 compared to the general population. We see this for the children aged 0 to 9, but we also see this for older populations and for age groups such as 30 to 90. Then we have another determinant, which is important when we talk about the transmission risk and the exposure risk, and that is the working condition, so the condition under which we work. And data from the European Union has found that less educated people are less likely to work from home compared to people with a higher level of education. And we can see that in this graph here, for example, which shows data from the EU, so 27, so the 27 EU member states. And it shows that especially people with a primary level of education, that means they don't have education to enter a university, for example, and usually stopped going to school after 10 years, have are less likely to work from home compared, for example, to people with a tertiary education. Those are people that actually have an academic degree. And this is also because people with a primary or secondary education are more likely to be concentrated in the sectors that were determined as key sectors during the pandemic in Europe. And these included, for example, health and commerce and hospitality. So a big share of people with a primary or secondary education usually work in sectors such as agriculture, construction, industry, health, commerce, and hospitality. And of course, these key sectors also didn't allow people to work from home in healthcare. We all know that was just impossible, but also the transportation system in Europe wasn't put on hold. So we still needed bus drivers and taxi drivers and so on. And industry especially, although numbers of working hours were significantly reduced, in the industry, still a lot of people were unable to work from home, especially if they were working on the assembly lines. And in Germany, we had a big outbreak in a meat production factory in the second wave of the pandemic. And because the factory did not only not adhere to the social distancing rules, but it was also a lot of people coming from Poland that were living in housing provided by the factory. And again, those was closely related to the overcrowding in the houses because the housing conditions were precarious and because they were exposed to the COVID-19 at work and at home. So they basically had no chance of escaping. So whether they were going to work or staying at home, they were under various precarious conditions and simply not able to isolate themselves. So when we sum up part one, we see that we have an increased burden of COVID-19 among socially disadvantaged groups. This is due to either the increased susceptibility and vulnerability. And this is, for example, due to the higher burden of pre-existing health conditions, such as diabetes, respiratory diseases, cardiovascular diseases and obesities, and these pre-existing conditions increase the risk for severe COVID-19 disease course and mortality of COVID-19. And also these comorbidities arise, and I think that's very important, of the inequalities in the social determinants of health. We have seen that people with poorer working conditions and poorer people or people from economically deprived areas are more likely to suffer from certain diseases compared to others. Then the second pathway includes the increased exposure, and this is linked especially to living and working conditions. Lower paid workers, particularly in the service and in the industry, were more likely to be designated as key workers and therefore required to work during the lockdown. And unable to go work at home. And another pathway or determinant was the poor living conditions. And this is closely linked again to income and your employment status. And especially overcrowding increased the risk of transmission and exposure to COVID-19. And now we will talk about the indirect effects. So not only about the direct effects of COVID-19 itself, but also about what the pandemic actually caused for inequalities throughout the pandemic waves. And we will talk about the health and especially mental health consequences and the psychosocial strain. And And given the short amount of time, I will first focus on mental health, and then I will focus on especially psychosocial working conditions that have changed and are experienced unequally throughout the pandemic. There is no doubt that the COVID-19 pandemic and lockdowns had a huge impact on people's mental well-being. We experienced an increase in mental health problems across the EU. And it is actually very surprising that not surprising, but it's stunning that the mental well-being decreased, especially for young people and those out of work. And data from the European Union showed again that particularly people out of work and with lower income and lower socioeconomic status in general had lower rates of mental well-being compared to more advantaged groups. And to exemplify, we can see here a study from one of my colleagues from Germany, and he compared data from the national cohort study of Germany that is conducted cross-sectionally and regularly. And we see that depression increased from 2014 to 2020 by at least 2.4% or even 1.5% for anxiety. And this, for example, here represents the pre-COVID cohort, so data collected prior to COVID from 2014 until 2019, and then the COVID cohort, and we can see that severe depressive symptoms, so a PHQ-9 score above 10, and this is a very valid measure for assessing depressive symptoms, and the J87, which is an anxiety measure above 10, show that it significantly increased from, for example, 2019 to 2020 for depressive symptoms, and again also for anxiety. So a lot of mental health problems occurring during the COVID-19 pandemic. And people are also trying to explain why we have such an increase in mental health problems and the factors that are behind it. And one study, for example, wanted to look at how lockdowns are associated with the psychological impact of the COVID-19 pandemic and the lockdowns. And there has been, of course, a substantial variation in how governments and communities around the world have responded to COVID-19. So we have various types of lockdowns. I mentioned earlier, Italy, Spain, and France were more strict. Germany and Sweden, and especially Sweden, were more laissez-faire. They had lighter lockdowns and people were still able to go outside. And Prati and colleagues finally decided to do a meta-analysis, and they found a small but significant effect for COVID-19 lockdowns on mental health. And they saw that, there was a great heterogeneity in mental health outcomes, and this is, like I said, most likely due to the different measures that every country has put in place to reduce the spread of COVID-19. And of course, we now also have to ask the question, does it have an equal impact for all? Because we saw that when we looked at the indirect effects, there were strong inequalities in experiencing COVID-19 and the disease course, mortality, infection risk. So how does it look like now for health inequalities during COVID-19, like mental health? And as so often, the burden also here is not equally distributed. In this study from the UK, for example, a clear social gradient in experiencing anxiety and depression and adversity is visible. So cumulative numbers of worries and the experience of adversities were both related to higher levels of depression. but this was more so in disadvantaged groups compared to the less advantaged groups. And the authors here, Wright and colleagues, calculated an index for low socioeconomic position, and this included, for example, income, education, and housing. And you can see that even though it's slightly, for anxiety, people with a low socioeconomic position score had a higher higher scores for anxiety when they experienced adversity and also worries, and the same is observed also for depression. Again, when we look at the green bar here, or the green line, we see that it is slightly higher, especially for worries compared to people with a low socioeconomic position index. So those people who are more advantaged and have higher income and higher education and so on. Then we have psychosocial strain during the COVID-19 pandemic, and especially in the financial situation. And also there we find inequalities, and it is not equally distributed among the population. And we see especially differences in the development of concerns about one's own economic situation in Germany. And this data actually shows a German analysis of the socioeconomic panel, which is a big study in Germany that collects data on socioeconomic and sociodemographic information in Germany. And we can see that the financial worries differentiated according to education groups. So here we have low education, people with a middle education, and a high education, which is usually an academic degree, non-academic degree, and again, many not having completed education at all, or only a few years of education. And we can see that those with a higher level of education in orange are worried less about the economic situation, and we can see that throughout the years. So in 2015, 16, it even decreases a little bit. Then in 2019, it increases a little bit, and then in 2020, it decreased even more. And people with a higher level of education were far more likely to indicate that they were worrying about their finances or the economic situation compared to people with a lower education. And when we look at the trend here, we can see that it remains pretty stable. It increases, then it drops sharply in 2008, and then increases again in 2019, and even a further increase in 2020. And this is most likely due to the fact that a lot of people in precarious working conditions, and those are unfortunately those with usually with a lower level of education, were put on short-term work. So in Germany, they were not fired, or the businesses didn't let their people go, and people became unemployed, but they reduced their amount of working hours. So people were experienced significant decreases in their economic income and in their salaries. They still had a job, they were not considered unemployed, but they were only getting a certain percent of the income, which put a lot of people at financial strain because they were unable to afford their housing and to provide or buy healthy foods, etc. This study from the UK also explored the changing patterns of adversity relating to the COVID-19 pandemic, again by socioeconomic position. And they did this during the early weeks of the lockdown in the UK. And we can see that the socioeconomic position was composed, we can see that, but the socioeconomic position was composed, for example, of employment status and housing tenure. So did one own a house, or did one rent a house? Did they have to pay for rent, or were they living rent-free? And household overcrowding. And we can see that adversities included, for example, financial adversities, accommodation, access to sufficient food, and access to medication. And there is a clear gradient, as we have seen in the other studies, that across the number of adverse events experienced by each week and by the socioeconomic position. And again, those with lower socioeconomic position scores experienced far more adversities compared to those with lower socioeconomic position scores. So here again, we have a low socioeconomic position score of 2, and they, especially at the beginning of the pandemic, had far higher scores compared to people with lower socioeconomic position scores. Then again, we have the psychosocial strain arising due to working conditions. And although teleworking in Germany and Europe was a key factor in ensuring the business continuity, it has led to the rise in the number of people working from home, especially, as I mentioned, in non-key sectors such as administration and management. But this has also resulted in difficulties in managing one's private and work life. And we sometimes refer to this as work-life balance or work-life conflict. And we have seen that especially at the beginning of the pandemic in April and July, through all the 5 dimensions here of work-life conflict, this significantly increased, and people especially worried about their work when they were not working or were too tired to do some of their household chores. And this especially increased also when we compared data from 2015 with spring 2020. And this is one of the studies I did and that we have currently under review. We compared the 5 dimensions that I have just shown on work-life balance or work-life conflict from 2015 with data from 2020. And we can see that there were significant deteriorations in work-related adversities. We see, for example, that in 2015, the work-life conflict was experienced by roughly 16, 15, a little bit more than 20%, and that this increased significantly in spring 2020 to over 20%, and was especially present among mothers with young children. So we see a huge inequality in experiencing work-life conflict among female workers with young children. And we have performed this study not only for work-life conflict, but also for work-life balance and for being able to detach from work, so leaving work by side. And we see that the similar trend, it's increasing significantly from 2015 to 2020. And for all groups, we always see a stronger increase for female, especially with children. And this is most likely due to the fact that they still continue to take on most of the care burden in Europe. And I think in other countries it's the same, that female workers are still more likely to take care of the children and to fulfill the household duties. And then I think another very important and last factor that must be mentioned when we look at psychosocial strain or stress during COVID-19 is the increase in violence and conflict. And since the outbreak of the COVID-19 pandemic, data has been emerging and reports by the UN have been published that all types of violence against women and especially girls, but particularly domestic violence, has intensified compared to prior to the pandemic. And this graph that is shown here is actually also from Germany. And they looked at the prevalence of violence by home quarantine, so people that have been quarantined by because of COVID-19. And we can see that the prevalence of violence significantly increases when women and children were at home and unable to isolate themselves completely. And I don't think I have to go into depth about what violence for women and children means concerning their mental health, but we can expect that also there in the future we will see significant inequalities in the mental health of women and children compared to men. And that's already pretty much it. To conclude, I think I've mentioned this several times, and it became pretty evident that the COVID-19 burden in Europe is worse in disadvantaged groups, so people with less income, lower levels of education, people living in poorer housing conditions, which are all closely correlated. And we see that they have higher infection rates, worse disease outcomes and higher mortality rates, and also poorer mental health, and also suffer more from the health inequalities now arising during the pandemic. And as Claire Bambra, the professor from England, put forward, we are experiencing a syndemic pandemic. And this means that COVID-19 is interacting with and exacerbated by social, economic, and health inequalities. So the inequalities we experienced before the COVID-19 pandemic and the inequalities we are experiencing now are building this toxic relationship and are most likely due to even further inequalities in the future and after this pandemic is over. When we think about what we can do to fight inequalities in health, I think a good approach would be an a health in all policies approach, which can help to prevent the further widening of health inequalities. I think that especially when governments and Germany as well should face crisis, we should consider the social determinants of health in our policies and assess how policies affect the social determinants of health and how they can also lead to inequalities. And then the fourth conclusion would be to include the social determinants of health in pandemic preparedness planning. And in Germany, especially, social determinants are only now are gaining more importance, and it has not been particularly included in any plans, especially when it comes to pandemic preparedness planning, and is often not considered. And therefore, I think to prepare for future crises, not only pandemics, but also economic crises and pandemics, we should always consider the importance of the social determinants of health. And I thank you very much. And I hope this was somewhat informative. Thank you.
Thank you very much. You deal with a wide range of the effect of the pandemic, including direct and indirect effect. And we can see that the many statistics from Europe and Germany about the social determinant of pandemic effects. So thank you. This is Q&A session right now. So if you have question, would you please 마이크를 켜시고 질문을 해주시면 좋겠습니다.
I think the question goes on, right? Because he's asking about how people in Germany see health inequality as a problem. And I think that in academia, of course, especially we see health inequality as a major problem. I mean, that's my job. I do social epidemiology, and I look at health inequalities and why they exist and how we can prevent them and stop them from happening every day. And there are a lot of institutes in Germany that are looking at health inequalities. We have the Robert Koch Institute, which is the big national public health agency that is doing a lot of research on health inequalities. But we also have the Public Health Institute in Bremen, which is the north of Germany. And then in Düsseldorf, where I'm at, it's a big center, the Center for Health and Society. They especially look at working conditions and health inequalities. And when I think about if inequality is a big problem, when I think about the general society, I don't think they have realized of how big this problem actually is. I see that when I teach the medical students and we talk about poverty and health, that sometimes you can't hear it, but you see that it clicks in their brain that actually poverty and health are associated, and that there is a relationship between being poor and health. And I think that this is something that still has to be communicated much better and more intensively in the German society. But to be positive, I think we are on a good way, because we got a new government in Germany last year, and they decided to integrate the social determinants of health and actually also name health inequalities in their coalition contract. So we are reaching also policymakers by our research, and I think that's very fulfilling and satisfying, and yeah, good that our research actually contributes to something.
Hello, Dr. Backaus. My name is Miku Gang from Korea University. I'm a PhD student and a preventive medicine physician. Actually, I have a same research interest: COVID-19, health equity, and mental health. So now I'm working in my paper. I analyzed 6 years data of the Korean community survey, and it showed the difference patterns between age, gender group, especially. Young people have worsened mental health, but the older age not really worsened. So I also wonder what is the pattern of Germany in case of Germany between age and gender. Thank you.
Yeah, so I think we have seen that with the European data. I cannot say right now specifically for Germany for age groups, but we see that younger people are more likely to suffer from mental health problems, and also women are more likely to experience poorer mental health. Sometimes this is a bit dependent on the pandemic wave, I feel like. So at the beginning, it was mainly men. We saw that also when we looked at working conditions, but then it is changing to especially women right now as well. And I think that's mainly due to the double burden they are experiencing by taking care of the children at home and the household and being an employee and also a teacher. So it's also a triple burden, I guess we could say. There are studies are being developed and data is gathered right now assessing mental health in young adults. So I guess we will have some evidence soon. But very interesting research. You should look into the European data and you can make a comparison.
Thank you for your explanation.
For your presentation today. I'm Dan Kim from Seoul National University. I'm doing my PhD in public health, and I'd like to ask you 2 questions actually. First one is inequality in ethnicity, because we know that Germany is quite generous about asylum seekers and refugees in European countries, but I don't think I have heard about ethnicity today, especially. So whether people in Germany during the pandemic thought about ethnicity and other issues about, those things, especially inequality things, whether they are more generous or they are more strict about asylum seekers or other things. The second thing is the Robert Koch Institution, is that a national medical center? So I'm just wondering whether they are producing news and information so that they daily produce news and information so that people in Germany generally know about news and information from the institution, or they just produce those information to the national government. So, do you know what I mean? Is that clear?
Yeah. Mm-hmm.
Okay, thank you.
To answer your first question about ethnicity and race, actually we have very limited data in Germany about COVID-19 infections according to race and ethnicity, because that is something we usually don't ask people. We have a study that is going on. One of my colleagues is doing that, that is starting to collect data on race and ethnicity. but often we have a lot of missing data when we do these studies, so people don't even indicate it. Thus it's hard for me to say if there are any differences. I guess it would be more wise to look at European data. And we do see, though, that in Germany, usually people with a migration background have poorer health status and are also less likely to seek help from doctors or medical professionals. And I mean, they do have health insurance most of the time because that is required by the German government. So it is not a matter of not being insured. It's rather a matter of them probably not knowing how to get information, where to find the information, and that they can actually get help. So I guess it's more a problem of the health literacy and competence. But I can't answer questions to COVID-19 because the data is so scarce. Yeah. I hope that answered your question. Okay, and then regarding the second question, whether the Robert Koch Institute provides information, they actually publish a daily report. I think they still do it. I'm not sure if now, but for the longest time of the pandemic, actually since the pandemic started, they published a daily situation report, both in German and English, about the COVID-19 infection rates and death rates. And they also did more stratified analysis by age, for example, and by gender, and that is freely available to everyone. It's not only for the local government or in general the government, but is for researchers, for the public. Everyone can access it through the website. And if you're interested in it, I can also send you the link. I don't know if that would help you. But yeah, but again, I think that a lot of people are not so interested in the reports. At the beginning of the pandemic, everyone was interested in infection rates. I mean, it was all over the news. It was nothing. We all talked about how COVID-19 spread. And then I think the longer and longer the pandemic lasted, the less people became actually interested. And I don't know, maybe that's your experience in Korea as well.
Thank you for the good lecture. I am Arin Choi. I am a researcher of Institute of Community Care and Health Equity. Through the lecture, I could figure out there are many socioeconomic inequalities in the infection, hospitalization, and mortality of COVID-19 in Europe. I think many inequalities are similarly occur in Korea. However, I think hospitalization trend in Germany is different with Korea in COVID-19 period. People who have low income level could not be hospitalized in Germany, even though they have severe symptom of COVID-19, I guess. Do you think why? Because the medical cost is expensive, or there was not space for them?
I don't think it has anything to do with cost, because in Germany, everyone has equal access to healthcare, and we have a very good social security system that also provides the same healthcare to everyone. So I think, again, it has more something to do with the working conditions. So people with a lower income usually work under more precarious conditions. And they are also, and that's something I haven't mentioned, prone to presentism. So they are more likely to go to work when they are sick because they are afraid of losing their job. And they already have a low income and a precarious working conditions. And if they then stay away from the job, they're even more afraid that they might lose their job. And I think, again, it has also something to do with a bit of competence, not to mean this negative, but because it correlates with education as well, that they don't seek the doctor because if they have a fever, they don't necessarily think to go to get tested. I think that, but I have to speculate about that. So this is nothing I can say for certain because we don't have the data, but this would be my hypothesis, that they are less likely to seek care and that they are more likely to go to work when they're sick. And that's also where they are more likely to get infected. And then they only go to the hospital when it gets really bad. So they are also more likely to go to the hospital much later than other people. And yeah, so when the disease has already progressed so much that they can't breathe, and they actually often get tested positive once they enter the hospital. So they didn't know they had COVID. They only get to know it once they're in the hospital.
So thank you so much for your great presentation today. And I think this will be a great chance to get the many knowledge and the lessons to many audiences from your presentation. And we can expand our research theme and our thinking to the COVID-19 vulnerable population and social determinants of health and psychosocial strain.
Thank you, everyone. Thank you for listening, and thank you so much for having me. And yeah, it was an honor. Bye-bye.